Good evening, everybody. I thank AstraZeneca for this opportunity. We are going to discuss bladder cancer today. I'll just start with the opening remarks and the context setting, and it will be followed by a talk by Dr. Anand Raja, my good friend, who will be speaking on radical cystectomy versus trimodality therapy in bladder cancer management, followed by a talk by Dr. Haridas Mani on paradigm shift in the management of MIBC, and then we'll wind up by having a panel discussion. So a lot has happened in bladder cancer. For many years, we didn't have any advances in bladder cancer management. In any cancer, for that matter, it's usually the nuances are there in the stage 2 and stage 3 management. Stage 1, all of us know surgery is the treatment of choice, and stage 4, we all know it's either palliative chemo or palliative chemo plus immuno or best supportive care. But when it comes to stage 3, we all struggle and then how to sequence the treatment. In bladder cancer space, nothing much happened for many years. It was always radical cystectomy, and then we used to give adjuvant chemotherapy, which had some 4% or less than that benefit, absolute benefit. And then came the concept of neoadjuvant chemo because they would tolerate all the chemo before the surgery. And then that showed definite benefit of 4% or more in the neoadjuvant setting. And then came the concept of bladder conservation with incorporation of radiotherapy. So we'll be discussing all those points in muscle invasive bladder cancer. So superficial bladder cancer most of the times would be managed by urologists. And when it comes to muscle invasive bladder cancer, multidisciplinary approach is very important. And there are a lot of disruptions with the advent of immunotherapy. And also after the Niagara, the entire concept has changed now because most of the bladder cancer patients, they may deny to undergo cystectomy is one thing. And most of them are elderly and they have renal dysfunction. And it's a challenge to give cisplatin. They are cisplatin ineligible most of the times. And with Niagara, what it showed was that split dose of cisplatin is doable. And we have seen in our practice that it is doable and has less toxicity and more patient friendly. And splitting the 70 mg per meter square to 35 mg per meter square day 1, day 8 has changed a lot and it has improved the quality of life of the patients. And then incorporation of radiotherapy is always there. And with the advent of durvalumab in the neoadjuvant setting, we are seeing a lot of pathological complete responses. And the major disruption would be in the future would be this enfortumab vedotin and pembrolizumab, which is there in the metastatic setting, and it may come in the future in the neoadjuvant setting. And then we may see a lot more PCRs. It's already in the pipeline. And then a day may come when we see patients of bladder cancer not undergoing surgery, that to muscle invasive bladder cancer, that Dr. Anand Raja will touch upon that. And when it comes to bladder and rectum, we are always very happy when we conserve somebody's bladder or rectum. See, we always talk of breast conservation surgery and larynx preservation, but when it comes to bladder and rectum, if the total neoadjuvant treatment is done and we save the bladder or rectum of patient, it's more rewarding and patients are also a lot more happy. And not all are willing for radical cystectomy, which is the treatment of choice and which has been the gold standard for many years. But that paradigm may change in the years to come. So we'll touch upon all those points and also discuss the nuances of multidisciplinary approach, how to sequence the treatment and how to treat difficult cases. So then now over to Dr. Anand Raja, my good friend, who will be speaking on radical cystectomy versus trimodality therapy in bladder cancer management. Over to you, Anand.
Am I audible and is my screen visible?
Sir, you're audible. Sir, just requesting if you can make it full screen, sir.
Yeah, I made it full screen. Can you see it now?
Yes, sir. Yes, sir. Please go ahead, sir.
Okay, thanks to Dr. Patil. I think both of us, he was slightly senior to me during our super specialty training, and a lot of the things that I know today are shared learning where, uh, the medical oncologists, the surgical oncology trainees, all of us sit together and learn and study together. So, a big thanks to him, a big thanks to all of us for the learnings that we've had. So, the topic for today is that I've been given to talk today about is radical cystectomy versus trimodality therapy. Before we start off, we know that the gold standard, so it doesn't matter whether you give radical cystectomy or trimodality therapy. What you need to do is to have adequate local control. Now we know that radical cystectomy has stood the test of time. It is really the gold standard against which all local therapies have been compared for local control as well as for regional control. Trimodality therapy again is emerging as a very promising modality wherein you don't have to do surgery, but you need to give radiation. But the questions that we need to answer are threefold. One, is trimodality therapy by not doing surgery, just by giving radiation, can you give oncological outcomes that are equivalent to radical cystectomy? That's the first question that you need to answer, that all of us need to answer. The second question that we need to answer is, if you can give equivalent control, is radical cystectomy for all, or can you offer it like a garden variety, radiation for all walk-in patients who have muscle invasive bladder cancer? And the third question that we need to answer is, if oncological outcomes being equivalent, does toxicity dictate which patients get what kind of treatment? So when oncological outcomes really are equal, it is usually the toxicity or the need for additional treatment that determines which treatment gets a slightly preferred option, so on and so forth. So the aims of treatment, as always in any muscle invasive bladder cancer, as in any cancer, are eradication of the tumor. You should leave behind no to minimal no disease. You should have minimal recurrences. You should have preservation of normal urinary function to the best of your abilities. You should have preservation of sexual function, and patients should not have need for additional modality of therapy, and you should prevent side effects as much as possible. So we know that radical cystectomy plus, like this is something that I've already said, radical cystectomy plus lymphadenectomy, whether you do standard pelvic or extended, has is the gold standard. The data now is again, as very beautifully told by Dr. Patil, has now gone up to neoadjuvant chemotherapy, now to neoadjuvant immunotherapy, and now with with other molecules coming in the neoadjuvant space, that might this paradigm might shift slightly. Bladder preservation protocol or trimodality therapy, as of today, in my opinion, is not for all, is for a selected few patients. So what does NCCN? So before we go on to eminence-based medicine, let's go at evidence-based medicine. And what do major guidelines recommend? So NCCN mentions that bladder preservation is a category 1 recommendation for stage 2A and for stage 2 and for stage 3, but not for all, which means to say that in the T3, T4 disease, or in the high nodal burden positivity, where you may need to give a lot of radiation to the pelvic sidewall for radiation, there may be bladder preservation is not the way to go ahead. Bladder preoperative regimes and bladder preservation are both in the same category. So what do the European Association of Urology guidelines mention? So it says that that patients should be counseled for TMT. That's a very strong recommendation, but they also say that bladder monitoring is essential. Now, TMT is generally reserved for patients with solitary tumors, smaller tumors, no or extensive focal CIS, or only unilateral tumors with related hydronephrosis. And they should already have had good pre-treatment bladder function. If you're going to have a small bladder, thimble bladder, then you give radiation. I mean, that's not going to help anybody. Now, why did TMT not really take up for very much for a very long time? Because the salvage cystectomy rates were up to 50%. When you say salvage cystectomy, it means one of two things. It means that if you've given radiation for 100 patients with bladder cancer, some of them will develop a recurrence for which you do a cystectomy, and some of them will have complications of cystectomy, like a hemorrhagic cystitis or a thimble bladder, where the patient is going and passing urine every 5 or 10 minutes, because of which you go ahead and do a cystectomy. So that is called as salvage cystectomy. Now the salvage cystectomy rates were 100 and up to 50%, which means to say that if you treat 100 patients, you will need to treat 150 treatments to cure 100%. And 50% was unacceptably high. That's why TMT didn't take off in a very big way. But with advances in the technique of radiation, in the type of radiation, technology, IMRT, so on and so forth, they are able to give radiation only to the involved portion, spare a lot of the normal tissue. The toxicity comes down. The recurrence rate doesn't come down, but the toxicity sure comes down. So the salvage rates for cystectomy have kind of gone down from about 50% to about, in the community to about 30 to 40%. And in high volume centers, it's come down to about 10 to 30%. Again, important to remember here that we keep talking about, high volume centers, and that if you do surgery at high volume centers, the outcomes are very good compared to not so high volume centers. Similar is the case with radiation. If you have people who are giving radiation to the bladder consistently on a regular basis on high volume centers, the complications of radiation because of which you would need salvage cystectomy is far less in experienced people as compared to experienced centers compared to not so much experienced centers. And the last is we've spoken about the AUA and the NCCN. The EUA, EAU, what does the American AUA recommend? It says that patients should be offered radical cystectomy with a pelvic lymphadenectomy for all resectable muscle invasive bladder cancer, which is a strong recommendation, and that patients with newly diagnosed non-metastatic muscle invasive bladder cancer who have a strong desire to retain the bladder, who do not have significant comorbidities, or and those patients who are willing for lifelong follow-up to detect a recurrence and are willing for a salvage cystectomy should be offered bladder preserving protocols. Now, what does the data really talk about? So, if you talk about radical cystectomy, there's been no trial, head-to-head trial of radical cystectomy versus trimodality therapy. I don't think that will ever happen for various logistic and other reasons. But we do have, systematic analysis or match pair cohort analysis that have compared radical cystectomy versus trimodality therapy. So it demonstrates from this very high volume study where they've identified about 7,000 patients. They demonstrate an oncologic advantage of radical cystectomy over TMT for the CT2 muscle invasive bladder cancer. However, they did not find any difference for cancer specific survival for the T3 or T4 patients. Basically, you could just argue to say that there really was no survival advantage. It's just that it was a retrospective study with 7,000 patients. So maybe there's some small statistic jugglery that's happened there. Another study that has compared radical cystectomy versus TMT for MIBC, again, multi propensity score match study. The overall survival, there was no difference. Cancer specific survival, again, no difference. DFS also no difference. Now, here, overall survival, they've said favored TMT. This should not be taken as that TMT confers survival advantage in properly selected patients. For TMT will be those small tumors, those T2 tumors without CIS, without hydroureteral nephrosis. So in high volume centers, the best cases have been taken for TMT and everybody else has been offered radical cystectomy. So that's why probably there's a survival difference in too much should not be read into that. But the important finding here is that if you've seen it in institutions that see a lot number of patients, the salvage cystectomy rates was only to the tune of about 15%. So comparative data from key studies, if you compare TMT versus radical cystectomy, if you go there, the main findings, there are multiple studies, again, which have shown that the OS is not significant across these studies. Some studies might find that, the hazard ratio for OS might prefer TMT or might prefer radical cystectomy. Again, a lot of these are retrospective studies. Case selection plays a very important role. So in properly selected patients, I don't think that survival would be different. Of course, if you're going to select patients for radical cystectomy who have large tumors, obstructive uropathy, CIS, so on and so forth, your survival is going to, to drop. Similar is the case with most other studies that are there. So, what is the ideal patient for a TMT? So he or she should have T2 disease, T3, T4 might not be the ideal candidate, should have complete TURBT, should have no hydroureteronephrosis, no CIS, unifocal tumor, and should have had good bladder function and capacity. This is like the one of the most important things, non-oncological but function related. So if you look at the real world evidence, what does real world evidence and the standard of care that is there for bladder preservation? So we know that for the longest period of time, bladder preservation was just radiation with chemotherapy as a sensitizing uh, dose of radiation and sensitizing chemotherapy. It did not usually include the classic neoadjuvant chemotherapy that kind of improves survival. So in today's day and age, we know that you can go ahead and give cisplatin, gemcitabine, cisplatin, or you can even go ahead and give dosed as MVAC. Then you can go ahead and give radiation, which is typically about 55 gray. With radiosensitizer, you're giving either 5-FU or mitomycin or cisplatin. And once the treatment is done, patients need regular follow-up with a cystoscopy periodically, 3 monthly for the first 2 years, 6 monthly for the next 2 or 3 years, and then annually. You also need additional CT scans because the cystoscopy does not assess uh, disease in the nodes. So you need to see for the nodes. The CT scanning, maybe you need to do a little earlier and have a very low threshold to consider radical cystectomy for complications or for recurrent disease. So we really spoke about the short-term outcomes. What are the long-term outcomes with in patients with muscle-invasive bladder cancer after selective sparing bladder preserving protocol with combined modality therapy? Again, if you look at among patients with a CR, on about 12 to 43%, that's about 15 to 40% of patients will develop a local recurrence. A lot of these local recurrences, depending on the center that you work from, there will be some superficial recurrences, some muscle invasive recurrences. A lot of these recurrences can be salvaged if they are non-muscle invasive by a TURBT. Of course, because it's got radiation, risk of perforation, so on and so forth is there. So we know that of all these recurrences, about 35% of them will be non-muscle invasive. Now, coming really to the big part of it about on quality of life and functional outcomes. So we know that again, a little bit of word of caution when we talk about quality of life studies. The main flaw in quality of life studies are that the same patient does not undergo both. Patients either undergo radical cystectomy with its complications or patients undergo cystectomy. So, and the human mind, is an amazing thing. So, because the same patient doesn't undergo both procedures, it is very difficult to compare. It's like comparing apples with oranges. So, most of the time, you'll find very little difference in quality of life studies when you compare cystectomy with trimodality therapy. However, if you just look at quality of life for TMT alone, a lot of patients will report that there are only no to mild urinary symptoms at 2 years. There's an RTOG pooled analysis which tells us that the late GU toxicity again is only about 5 to 8% at grade 3, and GI toxicity is 1 to 2%. Again, a little bit of importance here. People who are interested can go and read up. If you say that grade 3 toxicity is very, very low, what RTOG defines as grade 2 toxicity again is very important. Grade 2 toxicity would include that you get up 5 times in the night and that is acceptable. I don't think that is acceptable. So the way that these definitions have been defined is also very important. So one of the main complications again of this is hemorrhagic cystitis, which is a nightmare for us because you will have a lot of hemorrhagic cystitis, clots. Now you can't go ahead and give a lot of bladder lavage because the bladder will perforate because the bladder loses its suppleness. It is very tough. It is fibrous. The moment you increase the pressure inside the bladder, it increases. There's no then you'll have to go inside and try to suture the bladder back. Again, all that is a little bit of a catastrophe. So what we need is integration of multidisciplinary care, find the right patient, find the right candidate for the right treatment. Again, salvage cystectomy, like I said, is a little difficult. This latest paper came about 5-6 months back. It highlights the role of salvage cystectomy after prior trimodality therapy. So it tells us that while perioperative outcomes are comparable between salvage cystectomy and primary radical cystectomy, salvage cystectomy is associated with a lot of intraoperative blood loss. It may need more intensive care, and they exhibit worse overall survival outcomes, underscoring the importance of tumor biology on outcomes. So salvage cystectomy, I think I've already said this, is recommended for patients that do not achieve a CR or develop subsequent invasive recurrences or develop complications following radical cystectomy. So to conclude, radical cystectomy remains the cornerstone of curative surgery, of curative treatment. Bladder preservation protocols offer an alternative. They have a lot of challenges in terms of potential long-term effects of radiation, need for lifelong bladder surveillance, and there is also some data that there might be some better outcomes with radical cystectomy. Then again, I'm a little skeptical. I think that got to do with proper case selection, and trimodality therapy is not for all. It is for for radiation oncologists who are able to deliver it at high volume centers. Thank you so much. Thank you, Dr. Patil. Thank you.
Thank you, Dr. Anand, for a succinct presentation. It's always a delight to listen to you. It's not easy to treat bladder cancer. There are so many nuances. And as he rightly said, radical cystectomy is the gold standard and it has remained stood the test of time. And we should very carefully select for patients for bladder preservation. And also is nicely brought out the quality of life issues and what are the problems in assessing quality of life. And also there are a lot of challenges in treating bladder cancer because most of them are elderly, and we should spend that extra time to convince them for radical cystectomy and for ileal conduit because quality of life is a lot better with that, and it's a curative approach. And also we see patients with diabetes, chronic kidney disease, and whom we cannot deliver cisplatin. So to touch upon that, and then also there are a lot of changes which have happened with the advent of immunotherapy. And one cancer which truly requires, most of the cancers do require multidisciplinary, but bladder cancer, that is muscle invasive bladder cancer, truly requires multidisciplinary approach. And we should, the center of attention should be the patient, and we should all direct our approach towards uh, having a good outcome, survival, and quality of life. So now over to Dr. Haridas Mani, who is medical oncologist at Kaveri Hospital, Chennai, who would be talking on paradigm shift in the management of muscle invasive bladder cancer because we have perioperative immunotherapy, neoadjuvant immunotherapy, adjuvant immunotherapy, and cisplatin split dose. And Niagara has changed the way we look at bladder cancer. So over to you, Dr. Haridas Mani.
Sure. Thank you, Patil sir. Very good evening to all my seniors and colleagues. And Anand sir, it's always a privilege to hear you speak, sir. It gave me nostalgia when we were having our sessions, Saturday sessions, Friday tumor boards, and all with Anand sir. So used to be our base urology specialist.
Haridas,
Yes, sir.
small. I'm just checking it to a flight. I log in as soon as clear security. Maybe
Sure,
10
sure.
minutes I'll log in again. Thank you.
Sure,
Thank you.
sure. Safe journey, sir. Yeah.
Thanks.
So,
Yeah, I'll log in.
yes, sir. Sure. So over to my topic today, and I definitely thank AstraZeneca for giving me this opportunity to speak on this important topic of this muscle invasive bladder cancer. So more or less, what I've seen in my share of cancer cohorts with bladder cancers are basically low grade papillary carcinomas and non-muscle invasive bladder cancers, where then the urologist themselves taken the opportunity to give them the intravesical chemotherapy. Now, speaking on muscle invasive bladder cancer, that's my main topic, which is the paradigm shift in the management of muscle invasive bladder cancer. Can we go on to the next slide? So, talking about the global burden of bladder cancer, we have the 5-year relative survival, wherein there's almost 97.2% of patients have a 5-year relative survival if there's a carcinoma in situ, which drops down to 71.7% with the localized disease. And if there is any regional nodal disease, it's basically 39.5%, while there's only 8.8% of 5-year survival if there's distant mets. This is based on the tumor stage. It's the 9th most diagnosed cancer and the 13th leading cause of cancer deaths. We move on to the next slide. So, my topic for today is basically centered on muscle invasive bladder cancer, which is stage 2, stage 3A, and stage 3B. So we know that stage 2 is basically it's a tumor that's invaded the connective tissue and into the deep muscle layer, which is also known as the detrusal layer. This is one of the classical MIBCs, and it has a good prognosis, better than the T3 or T4. Now, any tumor that's invaded the perivesical tissue with one nearby lymph node is stage 3A, which is spread to two or more lymph nodes is stage 3B. And if it's involved the other adjacent tissues and organs, it's stage 4. Next slide, please. So our today's focus is basically based on stage 2, stage 3, and stage 3B. Now we know that T4A per se is basically PUV. That's how I remembered: prostrate, uterus, and vagina. These are locally advanced but potentially resectable. We've got the T4B disease that's basically invading the pelvic and the abdominal wall. And they are considered to be unresectable with the mainline treatment as systemic therapy, which is our focus. What are the main therapy options we have for MIBC? It's basically surgery, radiotherapy, and chemotherapy. No, we know that surgery is involving the removal of bladder and adjacent structures, as well as placing reconstructive techniques to compensate for the loss of structures which has been removed. Radiation, it's a very clear-cut practice wherein we select the MIBC cohorts where the bladder can be preserved or who are ineligible or are unwilling for undergoing surgery. We can also use it for palliative treatment. So chemo may be administered in the neoadjuvant setting or in the adjuvant setting, and the aim is to enhance the clinical benefits of the surgical treatment. Next slide, please. Now, the standard of care for all patients with MIBC is basically radical cystectomy. Now, there's a clear-cut scenario wherein we have to select the patients very judiciously, and it's very precise when we select these patients. So any MIBC patient can be selected. The clinical outcome is basically 50% cure with surgery alone, and it is highly dependent on the pathological stage. We've got bladder sparing partial cystectomy, wherein those which are superficial tumors present in the solitary tumors which is present in the dome of the bladder. And again, it's very highly dependent on patient selection. We have bladder sparing chemoradiation, wherein they are not of the in situ, they've got no hydronephrosis. And there's a maximal TURBT required in such patients with a 65% cure. 55% bladder is intact, and it's highly dependent on patient selection. We have neoadjuvant cisplatin-based chemotherapy. So basically, it requires the sole criteria basically is eligibility to induce cisplatin. And there's always a 5 to 10% absolute improvement in the overall survival compared to radical cystectomy alone. And we have adjuvant cisplatin-based chemotherapy for those high-risk post-RC MIBC patients, basically who are T3 and T4 or with node-positive disease. So they've got similar improvements as neoadjuvant treatment, but the data is less robust. And again, many patients are not suitable for adjuvant treatment. Next slide. So moving on to my two topics or two studies that I'm going to describe is the Vesper 05 trial and the Niagara trial. So moving on to the Vesper 05 trial, which is a randomized phase 3 trial, which evaluated perioperative dose-dense MVAC and GC, that's gemcitabine cisplatin for patients with MIBC. Now it's basically a multi-center randomized phase 3 trial. So we took non-metastatic muscle invasive urothelial bladder cancers, clinically T2 to T4, M0, M0. We also took those cases which had node positive and on adjuvant chemotherapy, and we randomized them in a 1:1 protocol. And we had neoadjuvant dose-dense MVAC, which is methotrexate at 30 milligram per meter square on day 1, 3 mg per meter square of vinblastine, 30 mg per meter square of doxorubicin, 70 mg per meter square of cisplatin on day 2, every 2 weekly for 6 cycles. Equal numbers in both the neoadjuvant cohorts with 218, 219 for the gemcitabine cisplatin arm also. And in the adjuvant trial, we had only a marginal number of, say, 30 and 26 patients. The primary endpoints was the 3-year PFS, and the secondary endpoints was OS and TTP with safety and toxicity. Move on to the next slide. Now, the major point of concerns that I have in this study is basically It was associated, that's basically neoadjuvant dose dense MVAC was associated with a significantly longer progression-free survival and TTP compared to the gemcitabine cisplatin, and it was considered the new standard of care by the authors. In any scenario, the 3-year PFS for the dose dense MVAC was 66%, as when compared to the GC, which was 55%, with a hazard ratio of 0.7. Now, the dose dense MVAC cohort was associated with a higher rate of organ confined disease and downstaging at cystectomy versus gemcitabine cisplatin. Moving on to the next slide. Now, around half of muscle invasive bladder cancers are ineligible for cisplatin-based NACT. Since the performance status is more than 1, they've got a grade more than 2 peripheral neuropathy. There's a renal impairment with the GFR of less than or equal to 60 ml per minute. They've got grade of more than 2 audiometric loss with an NYHA class 3 heart failure. Now, for those ineligible for cisplatin-based NACT, there's no standard of care alternative, and this is basically a high unmet need which exists in these patients. So, following radical cystectomy, these patients may be able to receive cisplatin-based chemotherapy in the adjuvant setting to enhance post-op survival rates. Moving to the next slide. Now, there's the existing unmet medical need in MIBC is basically there's a 50% recurrence of progression following radical cystectomy within the first 5 years, wherein the most of the recurrences occur in the first 2 to 3 years. Hence, as how Anand Raja sir has depicted, strict 6-monthly and 3-monthly follow-ups required. There's a 5 to 8% modest survival benefit from neoadjuvant chemo with radical cystectomy, and less than half of cisplatin eligible patients receive this neoadjuvant chemo. The restricted patient population eligible for immunotherapy are restricted as benefit has shown in only selected population with high risk PD-L1 positive cohorts. And there's a lack of significant OS in the current adjuvant immunotherapy in the MIBC studies. Next slide, please. Now, I just would like to again, emphasize on the Vesper trial that some limitations on the trial was basically the primary endpoint was not met in the entire cohort. Though dose dense MVAC had an improved PFS, it did not meet its primary endpoint in the overall perioperative population at the pre-specified threshold. And dose dense MVAC basically, as we've got 4 huge aggressive injections, it showed a higher toxicity. And with basically, it was concentrated on the hematological perspective, GI perspective, and fatigue when compared to GC. A very low proportion of patients had basically had completed the pre-planned dose dense MVAC protocol. So it reflected tolerability issues in them. And again, there was also subset variability in this population as all the clinical subgroups did not derive equal benefit. And this is where we come to this Niagara study. So it's basically a randomized phase 3 trial of neoadjuvant durvalumab plus chemotherapy followed by radical cystectomy and adjuvant durvalumab in the muscle invasive bladder cancer. Next slide, please. Now, the study design basically was involvement of durvalumab along with gemcitabine cisplatin in one arm, and in the comparator arm, we had gemcitabine cisplatin alone. Durvalumab was given at a dose of 1,500 milligram IV every 3 weekly. The study population involved cisplatin and eligible individuals with clinically T2 to T4A N0 or N1 M0. They had the urothelial cancers or urothelial cancers with divergent differentiation or histological subtypes. The creatinine clearance, this is one important point here. The creatinine clearance was set up at a target of more than or equal to 40 ml per minute. And all had been evaluated and confirmed for radical cystectomy. So these patients were cisplatin eligible and also they were also candidates for radical cystectomy. They subcohorted these patients based on renal function with creatinine clearance of more than or equal to 60 ml per minute and between 40 to 60 ml per minute. Now, the PDL1 status was basically high versus low or versus negative expression. The Gemsite cisplatin dosing basically was cisplatin at 70 mg per meter square and Gemsite at 1000 mg per meter square for those patients with a creatinine clearance of more than 60. Split dosing for cisplatin 35 mg per meter square was also allowed at day 1 and day 8 with creatinine clearances between 40 to 60. And the dual primary endpoints taken were event-free survival and PAT-CR rates, while the key secondary endpoint was OS. Now, how do we define EFS? Any progressive disease that precluded a radical cystectomy, any recurrences that occurred after radical cystectomy, or those patients who did not undergo radical cystectomy within the expected date of surgery and any death from any cause. Now, we'll move on to the next slide. Now, if you look at this baseline characteristics, as we've mentioned, there were a large number of patients, almost 81%, with a creatinine clearance of more than 60, slightly minimal at around 20% in both arms, that's the durvalumab and the comparator arm, with creatinine clearance of 40 to 60. The nodal status was basically N0 in almost all the populations with 95%. Performance status is basically they have never taken up, more than or equal to 2. Moving on to the next slide. Now, comparing to EFS and OS. Now, if you look at the curves over here, perioperative durvalumab with neoadjuvant chemo had a statistically significant and clinically meaningful EFS and OS improvement. Now, if you look at the hazard ratio, it was 0.68. And the event-free survival at 1 year and 2 years was 76% versus 69.9% and 67.8% with 59.8%. For OS, the hazard ratio was 0.75 with the 1 year and 2 year OS data at 89.5 and 86.5 versus 82.2 and 75.2. Now, this is an interesting topic wherein I would say the number needed to treat in. Can we go to the next slide? Yeah. I'll just talk. I'll just describe this slide also. That's the PAT-CR in the intent to treat population. There was a formal analysis at Jan 2022, and there was an updated reanalysis at April 2024 because 59 of the omitted samples were again re-evaluated, and 28 samples were also added to it. So the formal analysis in Jan 2022 showed a 33.8% PAT-CR in the durvalumab arm, while a 25.8% in the comparator arm, that's GC arm. Upon reanalysis, it had increased to 37.3% in the durvalumab arm and 27.5% in the comparator arm. Now, can we just go to the previous slide? Now, this I'd like to just explain more because if you're looking at the number needed to treat at when you're looking at the event-free survival, I just had this calculation done. So it was basically 12.5 to 13 patients who needed to be treated to prevent recurrences for at 2 years. And interestingly, in both the cohorts, as I speak, we will go forward. With the slides. Can we go to the next slide? Again, the next slide, please. Yeah. So again, in this arm, yes. So if you're looking at the event-free survival in the PAT-CR and in the non-PAT-CR groups, so the PAT-CR had event-free survival basically of 92.1% compared to 84.8. In the non-PCR, it was basically 53.3% and 49.5%. Now, when you're looking at the number of events in both the arms, it was basically the same. How do we calculate it? We look at the event-free survival for both the arms, durvalumab arm and the comparator arm, which is 12% and 20%. So 0.2 minus 0.12 is basically 0.08. So 1 divided by 0.08 somewhere comes around 12.5. The same thing in the non-PAT-CR arm, 1 by 49% minus, 57% minus 49% somewhere around again 8. So again, 1 by 0.08 is basically 13. So the number needed to treat in both the arms was more or less the same. Yeah, can we go to the next slide? So even if what I meant to say in that cohort of event-free survival was when you're giving perioperative durvalumab, even if it had a PAT-CR or non PAT-CR, the number needed to treat was more or less the same, and it had a good probability of preventing one death or one recurrences, sorry, not death, recurrences after 2 years with 13 treated numbers. Now, moving on to the overall survival in the PCR and the non-PCR groups, perioperative durvalumab improved the OS in both the groups, which was basically 95.5% as against 91.1, while in the non-PAT-CR it was 75.1 was as against 68.9. Can you go to the next slide? And in the intent to treat, the OS hazard ratio is around 0.75. Now, when you're looking at the disease-free survival, that's DFS assesses the events in the radical cystectomy population recurrences after radical cystectomy or any death. Now, at Unity, which is the radical cystectomy plus disease-free, the number of events was 22% in the durvalumab arm as against 30% in the comparator arm, and it had not reached in both the arms with a hazard ratio of 0.69. So it reduced the risk of recurrence or death by post radical cystectomy by almost 31%. Next slide, please. Now, when you're looking at the PCR and EFS in the borderline renal function population, also that's in those cohort of patients with a creatinine clearance of more than 40 to less than 60 ml per minute, perioperative durvalumab did improve the PCR rates and the EFS in patients with borderline renal function too. So when you're looking at the odds ratio of 2.43, it was 32% in the durvalumab arm as against 16% in the comparator arm. And again, the hazard ratio for EFS was 0.69, and in the intent to treat population was 0.68. Next slide, please. Now, if you're looking at the overall period and safety summary, it was generally similar between the treatment arms and between the populations. Now, any grade 3 or 4 adverse effects for any cause was almost the same in both the groups. Now, treatment-related AEs was, again, it was more in the durvalumab as against 86% in the comparator arm. And any grade immune-mediated adverse effects was 8% in durvalumab as against 5% in the comparator arm. Can we go to the next slide? Now, again, if I'd like to prepare MCQs for when I used to prepare my, DM and all. So if I have to prepare an MCQ question, so I would definitely ask a question. So in which of these trials, if we've got the Niagara trial, the Checkmate 274, Ambassador, and Vigor. So in which of these trials did not show a favorable OS? So the answer was basically the Vigor trial. So this was the only immunotherapy agent, that is atezolizumab, which did not show a significant OS, wherein we've got the Niagara trial, Checkmate 274 Ambassador, had shown significant. Of course, the intent to treat and the cohort of patients were different in both the arms, wherein in Checkmate we had given nivolumab in the adjuvant setting, while in the Ambassador it was also given in the metastatic and in the adjuvant setting also. Going to the next slide. So as against what I had discussed previously, the Vigor 010 did not meet its primary endpoint of improved DFS with atezolizumab with placebo. So we had 390 patients with 397 patients in both the arms. Treatment-related adverse effects were more or less the same. The hazard ratio was 0.89, and the median DFS was 19.4 months, while for the placebo arm it was 16.6 months. Next slide. Now, this trial examines the response to adjuvant atezolizumab in high-risk MIBC who are having a circulating tumor DNA positive after surgery. So, post cystectomy, 6 to 14 weeks, and with lymph node dissection, we collect blood, and imaging was done for less than or equal to 21 months post cystectomy, and then a ctDNA was collected. So, in a 2:1 randomization, we gave atezolizumab at 1,680 mg every 4 weekly or every monthly, versus a placebo was initiated, and they were also to receive standard of care outside of the study. The primary endpoints was OS in the PAPs, the investigator, and DFS in the PAPs, and circulating glomerular clearance in cycle 3 and 5. So, moving on to the next slide. The Checkmate, that's 274 phase 3 study, evaluated nivolumab. So in this study also, basically, this is one of the oldest studies in textbook. It was done in 2020, if I'm not wrong. So the primary endpoint was DFS, and DFS in PDL1 more than 1% population. Again, they gave 1:1 randomization with nivolumab, 240 mg every 2 weekly, and placebo every 2 weekly. Next slide. So those who received adjuvant nivolumab had a significant improved DFS, which was against placebo. At 21 months, the median DFS was seen with nivolumab arm as against 10.9 months, the placebo arm, with a hazard ratio of 0.7. It received FDA from all the comers, and the EMA approvals were also patients for all patients with PDL1 of more than 1%. Next slide. Now, one pointer for nivolumab was the amount of immune-related adverse effects that it had, because amongst all PDL1 inhibitors or PDL1 inhibitors, we've got nivolumab as an immunotherapy agent which causes, more adverse effects, because it has a very deep, there's a word for it. I just forgot the word. So nivolumab basically has what do you say? The action. It's got a very deep action. So the immune-related adverse effects is far more in nivolumab as against other immunotherapy agents. So in my setting, if I've seen nivolumab usage, they've got lots of hematological toxicity with thrombocytopenia, hepatitis, and colitis, as against when I'm looking at other immunotherapy agents like pembrolizumab, the side effect profiles is much lesser. Now, again, the Ambassador was basically a study design where it was a phase 3 randomized open label study using adjuvant pembrolizumab versus observation in high risk muscle invasive bladder cancers. Again, post cystectomy patients, more than 4 weeks but less than 16 weeks, post neoadjuvant chemotherapy, that's YPT2 or YN plus, or cisplatin ineligible or refusing, and more than PT3 or N plus disease were the key eligible patients. So pembrolizumab was given at 200 mg 3 weekly for 1 year. Disease-free survival and overall survival with dual endpoints. Can we go to the next slide? So within a follow-up of 22.3 months, the pembrolizumab arm had met the DFS primary endpoint with a hazard ratio of 0.69. OS endpoint was at 0.98. It had not met, it was just an interim protocol that we've seen. It had not met its primary endpoint. Next slide. So at the ESMO 2024 setting, the medical follow-up as at 44.8 months, it showed a consistent DFS benefit. However, it did not present an OS result. Can we go to the next slide? Now, when we look at the guidelines, any guidelines for that matter, the preferred sandwich therapy is basically gemcitabine and cisplatin with durvalumab prior to cystectomy, and then durvalumab after cystectomy, which has a category 1 indication. Now, in the neoadjuvant setting, preferred for bladder, we've got DDMVAC with the growth factor support, and in certain circumstances, we give gemcitabine and cisplatin. Now, again, summary of evidence for perioperative durvalumab is basically 1B here. We'll go to the next slide. So in the version 2 of NCCN bladder cancer, that's MIBT210, all the primary treatment options that we've seen so far has been mentioned here. Of course, we have the primary treatment with neoadjuvant cisplatin-based combination chemotherapy or perioperative sandwich immunotherapy with neoadjuvant cisplatin combination chemo followed by radical cystectomy as category 1 here. Sorry. Can we go to the next slide? And in the adjuvant setting, we have got gem, cis, and durvalumab given preoperatively, and then durvalumab, which is given postoperatively. Now, based on the pathological risk, if no cisplatin NECT was given and the stage was PT3, T4A, or N+, adjuvant cisplatin-based chemotherapy should be discussed, and it has to be preferable. We can also consider adjuvant nivolumab or pembrolizumab. If, however, cisplatin neoadjuvant chemotherapy was given and it's a YPT2, YPT4A, or YPN+, we consider nivolumab or pembrolizumab. Also consider adjuvant RT in selected patients which are PT3 or 4 with positive nodes, positive margins at the time of surgery. Next slide. And so any muscle invasive bladder cancer, which is T3, T4A, N0, or T1 to T4A, N1, the primary treatment, which is a category 1 indication, is basically giving neoadjuvant cisplatin-based combination chemotherapy or perioperative sandwich immunotherapy. Next slide, please. So the conclusions. Niagara demonstrated statistically significant and clinically meaningful improvement in the EFS with hazard ratio of 0.68 and OS of 0.75. Perioperative durvalumab in the radical cystectomy population improved the PCR rates to 42% versus 33%. It reduced the risk of death after RC by 31%. The DFS benefit was across all the pre-specified subgroups in the PATCR and in the non-PATCR groups. With borderline renal function also, it had an improved PCR and AFS with the perioperative durvalumab with a similar safety profile to the overall study population. So again, this analysis from the Niagara provides further support that perioperative durvalumab with NAC is a new treatment for patients with cisplatin eligible MIBC. Now, even we do talk about the Niagara protocol, but again, so there are some pointers here. It had an open label design. So the hard clinical endpoints were basically robust. So again, there may be some biases in there. So there were also uncertainties about which subgroups had benefited the most. So the patient selection basically using PDL1, see molecular subtypes, CT-guided DNA, it still needs some kind of refinement. So there are also some patients who may be exposed to the additional toxicity without incremental benefit. So from I'll just end my slide with some practical clinical takeaways. Now we've got a fit cisplatin eligible MIBC. They can tolerate immunotherapy. I would vouch for perioperative durvalumab with standard cisplatin NEC, and that's based on the Niagara protocol. And now, if there are, patients who are not fit, not cisplatin eligible, but they are fit for surgery, I would go for radical cystectomy. That's it. Thank you, Patil sir, and thank you all for your patient listening.
Thank you, Dr. Haridas. It was a very clear presentation. You have dissected all the trials of perioperative and adjuvant immunotherapy and also usefully given the takeaway points in the end. So we'll go for panel discussion now. So what we'll do in panel discussion, we need not discuss all the slides in detail because most of this has been presented by Dr. Haridas already. He has presented about Ambassador trial and nivolumab trial and the Artizo trial and also the Niagara trial in detail. So what we will do is we'll dissect out what we do in clinical practice, because what is important in panel discussion is what are the take-home points, what are the take-home messages, and how we navigate the nitty-gritties of clinical practice and how we address the day-to-day problems. Because clinical practice is different and evidence and clinical trials are different. See, at times we see, most of the times every day in OPD we see that the patients are entirely different. They are not that fit. They are elderly. They have CKD and they have high creatinine and they have issues receiving cisplatin. So what we will do is we'll dissect out the principles of treatment and how we approach a case of bladder cancer. And we have all the panelists with us: Dr. Supreet, Dr. Vinu Sarathi, Dr. Balaji Krishnan, Dr. Ravichandran, Dr. Preetham Dev. And I request Dr. Haridas Mani and also if Anand Raja can log in to join the discussion. So we'll start with the panel discussion. We'll discuss what are the nuances of management. So we all of us do agree that radical cystectomy is the gold standard. And is anyone for adjuvant chemotherapy rather than neoadjuvant in this era? We can start with Dr. Supreet. So what's your take on adjuvant chemo versus neoadjuvant chemo in
No,
muscle
sir.
invasive? Yeah.
Hello, sir. Hi. No, sir. No, my preference would be neoadjuvant chemo if the patient is cisplatin eligible. Full
Yeah.
stop.
So which patients you would directly subject to radical cystectomy without taking up for neoadjuvant chemotherapy?
So there are this bunch of cisplatin ineligible patients for medical reasons too, because of the lesion itself.
Yes.
Because quite often we see the bladder tumors, they would be occupying the vesico-ureteric junction, causing some obstructive uropathy, which doesn't get relieved even with stent placement or even with TURBT, recurrent urinary tract infections. So these are the patients probably I would see them as surgically cisplatin ineligible.
Yeah, very clear, because we do at times see patients where we cannot deliver neoadjuvant Gemcis or dose-dense MVAC. And in that setting, it's always, if the patient can undergo only one treatment for better quality of life, we accept that 5-year survival of 20 to 25% and forego that 4 to 8% benefit, then the best option would be to do radical cystectomy, whatever Dr. Supreet has mentioned. He has mentioned all the points which are very clinically relevant. Can we go to the next slide, please? So
So I'm Dr. Ravichandran.
yes,
I would like to
Ravichandran.
make one point. So patient who are cisplatin eligible, there is a phase 2 trial where they tried single agent pembrolizumab, where it showed like a very good numbers like pathological complete response rate of around 20 to 30%. Would you like to consider like immunotherapy in these kind of patients?
Yeah, we'll come to the neoadjuvant immunolone. It's a very good point, because we have this new kid on the block, that is IVO, which can be employed as neoadjuvant therapy. And we have this EV plus Pembro neoadjuvant also coming up, which is going to light up the scenario. And there, the classification that is cisplatin, as Dr. Ravichandran clearly mentioned, this classification may no longer be there, whether patient is cisplatin eligible or ineligible, except if the patient has neuropathy. We should be very cautious while giving enfortumab vedotin, because it's an antibody drug conjugate which can cause severe neuropathy. But this is a very traditional way of distinguishing or classifying patients, whether they are cisplatin eligible or ineligible. But that may be a gone era now with the advent of pembrolizumab. As I rightly mentioned, we do see good response rates, and then even pathologic CRs. And we'll come to that neoadjuvant immunonegativities. So anyone for Dr. Vinusarthi can take this. Now, what's your take on dose-dense MVAC versus Gemcis? So have you used dose-dense MVAC in your clinical practice?
Hello, sir. Good evening, sir. Sir, I have used sparingly. So I've used only in a couple of patients where one of them barely tolerated and others could not tolerate beyond first cycle. So I usually stick to gemcitabine cisplatins.
Dr. Balaji Krishnan, your take on dose-dense MVAC?
Yes, sir. Clinically, I had given to one patient, and patient has landed up. We have to interrupt the treatment because of severe toxicity associated with the treatment. So I clinically prefer to proceed only with Gemcis, especially in the Indian setting.
Yeah, I completely concur with Dr. Vinu and Dr. Balaji, because our practice with dose-dense, our experience with dose-dense MVAC has been very dismal. But we do see in clinical trials and papers that it is equivalent to Gemcis, and it can be easily delivered. And only the conventional MVAC has no advantage, but it has to be dose-dense MVAC with growth factor support. But we are all uncomfortable with using methotrexate, vinblastine, and adromycin and cisplatin all together. So we may have a lot of mucositis, and patients are elderly, and it may be very difficult to tolerate. And I also concur with you. Maybe I've used for only one patient, but we had to dose reduce a lot, and then the dose interruptions were many. So the patient eventually may not have benefit. So we all stick to gem-cisplatin. So coming to the gem-cisplatin, we'll dissect some points on gem-cisplatin. Maybe Dr. Preetham Dev can take this. So what's your take, Dr. Preetham, after this Niagara? Because we all struggle to give 70 mg per meter square in elderly patients with CA bladder, with all obstructive uropathy, or already if they are diabetics and have chronic kidney disease component. So how do you classify, and how do you negotiate this?
Yes, sir. Actually, I was hearing other things, and then most of the patient who was anatomically good, where there doesn't have any obstruction, and then we have cleared most of the tumor, and then they don't have the renal problems like prostate issues and all. Then we can go ahead and give a neoadjuvant chemotherapy with Gemcis. But some of the patients do have a lot of other complications where we cannot wait even for pembrol. So as we were discussing a little bit earlier, because they will be having hydronephrosis probably on one side or both the sides, then it's not a good plan to wait for some time. So radical cystectomy will become the treatment of choice at that point of time, sir.
Yeah. What's your take on the split dose of cisplatin, like it was done in the Niagara?
I personally don't have any other personal this things experience. I usually refer to a medical oncologist in our hospital.
Oh, thank you. So maybe Dr. Supreet can take that question.
Yes, sir. I think we used to follow this even before Niagara came up in patients in whom we were suspicious of them tolerating full doses platinum. We have been splitting, and only thing that Niagara brought is some evidence to it.
Yeah, we have been doing that in clinical practice. In fact, in cholangiocarcinoma, we are very comfortable giving cisplatin 25 mg per meter square day 1 and day 8. It's always a challenge to give 70 mg per meter square on day 1. And then when we split it, we used to do that in clinical practice, but we have the evidence now. And then what is important in Niagara, what Dr. Haridas clearly brought out was in patients who are cisplatin borderline creatinine clearance, the pathological CR was 32% versus 16%. So that's what is remarkable. So because they could achieve in patients with 40 to 60 mils per minute, pathologic CRs of 16% in non-immuno arm and 32% in the immuno arm. So that's very remarkable. So that's how we used to navigate and negotiate in clinical practice, and we have the evidence to do that now. So now coming to, before we go to the case, we have discussed or dissected what is neoadjuvant and adjuvant and what regimen we prefer and how we split the cisplatin and how to go about. And we all know that neoadjuvant is the way to go whenever it comes to bladder cancer management, that is muscle invasive bladder cancer. So now what's your take on why do you feel that Niagara was a success when pembrolizumab and nivolumab and all of them failed to show overall survival benefit, but Niagara was a success? So what's your take on that, Dr. Vinu Sarathi?
Firstly, I think it was a very well structured trial, and I think a lot of patients were node negative, sir. So I think they did take a good subgroup of patients. So I think because we do see a lot of 40-50% of patients are node positive, and I think where the adjuvant niveau almost 47% of the patients were node positive and still showed benefit. So that would be a question, sir, whether Durva, how do we incorporate in a practice, especially where we see people at a later stage, they come a delayed diagnosis with node positive, will we get the same benefit with Durva Lumab in the neoadjuvant settings?
Yeah, Dr. Balaji Krishnan, your take on that?
Because they combine the immunotherapy with the chemotherapy. Usually, the combination arm, because of the well-structured clinical trial, that could be one of the reason why it had shown better EFS and the OS. Because most of the trial has given adjuvant and just a single immunotherapy. So in multiple trials with different solid cancers, they had shown combination of chemo plus immunotherapy always resulted in better because it take care of the tumor heterogeneity, which has overcome with the combination. Could be that is the reason the trial had shown better EFS and OS.
Yeah, very relevant, clinically useful points. As you rightly brought out, there it was given with chemotherapy. There is synergistic action. That is one point. And one more point we should be mindful.
I would like to add one more point. The other two are like PD-1 inhibitors. This one is a PDL-1 inhibitors. Maybe there is some difference in the mechanism of action.
Yeah. Any other points you would like to add, Dr. Ravichandran?
Yeah, this one I would like to add.
Yeah, that is again a good point. But
So
one more, yeah.
I just have a point to make. We need to see 2-3 things. One, as it was rightly suggested earlier, it was combined with chemotherapy. The second thing is when the tumor is in situ, we always see that the immune checkpoint inhibitors act better because of the secretion of neoantigens or whatever. That is one thing. Second thing is in the comparator arm, if we see there is no adjuvant phase of treatment. Whatever it was just Genesis in the neoadjuvant surgery, and then that's it. So the adjuvant phase in the durvalumab arm must have brought about some additional benefit, which was not visible in pembrolizumab trial, probably for various reasons, because the pembrolizumab trial included some of the low risk subgroups. And as far as I remember, around 40% of the patients in the pembrolizumab arm in the trial received neoadjuvant chemo, which means there was downstaging because of NACT, which has already happened before we even have given the interventional drug, which means we have selected some of the low risk population. There is dilution of the study population. So we cannot write off the role of adjuvant immunotherapy completely, is what I can take away from this.
Patil, can
Yeah,
I
excellent.
intervene and just say a couple of...
Yeah, Anand. Yeah.
Yeah. So I think everything that was said was just
Anand, go ahead.
absolutely brilliant. I said everything that was said was just absolutely brilliant about the Niagara trial, so on and so forth. But just a word of caution, in the sense that I think it's a reflection of the way that the industry has evolved, and the pharma industry has evolved, so on and so forth, that we get answers to questions that we are not asking. We get answers to whether durvalumab is working or not. We get answers to whether pembrolizumab is working or not. But none of them answer questions in the real world scenario, the questions that we ask. So today we know that the DD-MVAC, if you compare if you compare the trial of DD-MVAC with gemcitabine cisplatin, the overall benefit, the OS benefit was 5% extra, which means to say that if you don't do anything, if it's no chemo, it's 5%, is 0%. If you add chemo, there's a 5% survival benefit. If you add, instead of gemcis, if you give DD-MVAC, it's a 10% survival benefit. So the same quantum of benefit that you got from no chemo to chemo, you get by substituting gemcis with DD-MVAC. So we know that DD-MVAC works. Now I know that I am not the medical oncologist. There are real world problems, patient selection, patient acceptance, whether you will be able to give it, not, yes, so on and so forth. But we also know that, if you've given chemotherapy before, typically, gemcis, and then you have those pre-specified, pathologic factors, if it's a T3 or a T4 or an N plus, we know that nivolumab works better. Nivolumab versus nivolumab works very well. So the ideal trial for me would have been somebody you give DD-MVAC, do cystectomy or TMT, whatever, and then go ahead and give nivolumab, and then compare that with a durvalumab and then show some benefit. Unfortunately, that's not happened. So we keep talking about the Niagara. We say, chemo has worked and immuno has worked. My counter to that would be that, you can possibly go ahead and give DD-MVAC and do cystectomy and then give adjuvant nivolumab. You'd probably get more benefit out of this than the Niagara. Taking nothing away from the Niagara trial, it's brilliant the way that it's designed, but then, it doesn't answer real world questions in real world scenarios. Thank you so much.
Yeah, thank you, Anand, for the comments. I completely agree with Supreet and some points from Dr. Anand. See, the one thing what we have to understand is if we have to give immunotherapy, it's always better if we give in neoadjuvant setting. As Supreet brought out that point, because there are a lot of neoantigens. What Niagara exploited was this point. In fact, if you operate or give neoadjuvant chemo and then operate and then give adjuvant, there is hardly any benefit because there are no neoantigens and the immune exhaustion has already happened. That's why nivolumab showed benefit only in patients who had more than or equal to 1% PD-L1. Whereas when you give neoadjuvant, as we do in triple negative breast cancer, you don't have to look at the triple PD-L1 at all because the immune system is intact. There is no immune exhaustion. There are a lot of neoantigens. That point was exploited by Niagara. And dose-dense MVAC, that's why if we have to give neoadjuvant immuno, if we have to give immunotherapy, it has to be neoadjuvant. See, be it breast cancer triple negative, be it lung cancer, we have the evidence for nivolumab now. The same was exploited in the Niagara. That's why Niagara was successful. Whereas if you see the Ambassador trial or the Atazol trial, they had already undergone surgery or chemotherapy, and then they gave atezolizumab or pembrolizumab, and they could not show any benefit, overall survival. So that was the caveat there. But this was perioperative Durva. That's why there was difference. And coming to dose-dense MVAC, we all have difficulties in delivering dose-dense MVAC. But there is Niagara 2 trial, which is exploring dose-dense MVAC plus immuno in the neoadjuvant. That, as Anand mentioned, will be a clear winner. But we'll never have a trial which compares Durva versus Nivo. If you ask me whether tomorrow morning whether I'll give Gemcis and Pembro, that may still work in the neoadjuvant. But if you are a purist, then you will give Gemcis Durva. because you have the evidence. But I'm sure even Suprit, Ravichandran, all of them would agree, Vineet and we know, all of them would agree with me that if you give Gemcis Pembro in the neoadjuvant, you are exploiting the same principle and you are going to have benefit. And Ravichandran clearly brought out that point. There is a phase 2 trial who are not eligible candidates, frail patients. You give Pembro, we see a lot of pathology complete responses. So that's the concept of neoadjuvant versus adjuvant. If we have to give immunotherapy, the teaching point is we have to give it in the neoadjuvant setting and exploit that neoantigen environment. So any other comments on this neoadjuvant versus adjuvant immuno? That Suprit, you can start from here and then we'll go to Ravichandran.
Yes, sir. I think we discussed all the points. With the presence of tumor, we do expect better survival benefits with immunotherapy. The same was reflected in breast cancer also. We know that the adjuvant immunotherapy trial, which used avelumab, did not succeed much as compared to the Pembro trial. So as you rightly suggested, we need to give immunotherapy, if at all we are giving in the neoadjuvant phase B. And we are never going to get the comparison between neoadjuvant versus adjuvant.
Yeah. Ravichandran?
So I would like to add one more point. In the neoadjuvant setting, we have like intact vasculature. There will be better delivery of the drugs also. So that's what I would like to add.
Yeah. Even if you see in the lung cancer, so there is remarkable difference now. So PCRs with chemotherapy alone was only 4%. But if you add nivolumab, 3 cycles, just 3 cycles with PEM-carbo, the PCR rates are 25%. So where did we see that much? We never saw. That is because it is given in the neoadjuvant setting. Whereas if you do it after surgery in the adjuvant setting, we are not going to give any benefit to the patient. So now we'll dissect out post-surgery. So we have given we have done radical cystectomy and the patient has achieved pathology. Dr. Suprit and Dr. Vinu Sarthi can take this question. Dr. Vinu?
Sir.
Yeah, after surgery, there is PCR, and then would you continue Durva, or you will just observe the patient because anyway the patient has achieved PCR, and if you see the Gemcis arm, there the patients who achieved PCR, they did almost very well, better than the Durva arm in non-PCR arm.
Right,
this
sir.
debate
So
we
I think
always
even
have.
the
We had
opposite
this in the
arm,
breast cancer too. Yeah.
right, sir. I think in the opposite arm also they had significant good rates, 25 to 27% PCR, even the Gemcis. But here, I think till data matures, I would like to stick to the trials and continue adjuvant durvalumab. Definitely, sir. And because I think even in what we saw in the adjuvant Nivo trial, I think people who had received neoadjuvant chemo also they did better with the adjuvant immunotherapy. So for some reason, I think giving neoadjuvant chemo or neoadjuvant treatment primes the tumor, makes it more immunogenic. So I would continue adjuvant durvalumab also, sir, until we have a proper trial saying for pathological CR we could possibly stop it.
Yeah, Dr. Balaji Krishnan.
Yes, sir. I would also like to continue until the data is mature and there is a clear evidence that we can omit durvalumab, like adjuvant durvalumab, especially in patient who achieved PCR. Till that, I would also like to continue.
Yeah, unless the patient has toxicity, we would not drop the Durva in the adjuvant arm. So even if they achieve PCR, we would all continue durvalumab. So, and there is, as I mentioned, there is Niagara 2, which is going on, which is addressing dose-dense MVAC plus immuno, followed by radical cystectomy and then continuation of immuno. That's definitely going to show benefit because we all know that dose-dense MVAC is slightly better in all the trials have shown that it has slightly better responses and better PCRs, as Dr. Anand mentioned.
I wanted to add, I wanted to ask one question. Like a patient is having a complete T2 and he has a complete response, and we have done an cystectomy also. And do you feel still we have to give an immunotherapy after that, because we know that it was in T2 and we have completely resected also in TRBT. And in fact, we have given a neoadjuvant arm also. And still you feel there is a chance of micrometastasis in that patient or in subgroup, and still we have to give an immunotherapy after surgery.
Yeah, if the patient has received neoadjuvant chemo immuno, we would continue immuno. If the patient has not received neoadjuvant chemo immuno and has received only chemo and has undergone surgery, there is no role to give adjuvant because none of the trials have shown benefit. There is no overall survival benefit if the patient has not received neoadjuvant IO.
Sir, I just have a point to add in the presentation made by Dr. Haridas. there was EFS benefit in patients who had pathological complete response as well. So in the subgroup analysis, though the scale of benefit was lesser as compared to those who did not achieve pathological complete response, but there was still some benefit. So for that reason, I would continue.
Yeah. So yeah, all good points. And then we have dissected a lot of issues here. We have dissected neoadjuvant versus adjuvant chemo. We have dissected neoadjuvant chemo immuno, followed by surgery, and then adjuvant immuno. Then also we have dissected dose-dense MVAC versus GEMCIS. And also we have discussed cisplatin ineligible patient or upfront surgery options. And my now question is to Dr. Preetham, because we do see in clinical practice, sure that it is but to any
So,
muscle
sir,
in that.
there's a lot of voice break in between.
So, do you see often encounter? Yeah, we see in clinical practice that the urologist is sure that it is muscle invasive, but the pathology report comes out as no muscle seen in the sample. So, do you see that often in your practice?
So personally, I take care that I'll take an muzzle out of it and then send it. But we have seen that when it is done in the periphery and sometimes muzzle is missed, but we always take an second TURBT, re-TURBT and take the muzzle before diagnosing the disease or staging the disease.
Yeah. So we have covered most of the points. We just complete this case discussion. Can we go to the next slide? 62-year-old male presented with urea. And then obviously, Dr. Preetham, you can take the lead us to the work of this patient.
So 1 second, sir.
Yeah, Dr. Preetham.
Yes, sir. Yes, sir. Sir, I'll take up for first I'll do the CT and then diagnose the disease, what is exactly there. And then probably after that, followed by cystoscopy. And yes, I also do an cytology for this patient.
Yeah, next, can we have the next slide? Yeah, what imaging do you prefer, Dr. Preetham, whether CT for the pelvis or MRI pelvis, what would you prefer?
So I still feel CT because I also want to check in an upper tract also. And off late in the guidelines also has come up with MRI where the VIRAT scoring has come up. But VIRAT scoring is useful when we are not planning for any intervention like TURBT and all, we are not planning. Then it will tell us whether it is an infiltrative to T3 or T4 disease. But most of the time it is not very sensitive test, sir. So that is what we have seen in the clinical practice also. So that's why for us, the first important is CT urogram.
Yeah. Do you routinely ask for PET CT for staging investigation when you're sure that it is
No,
T3,
sir.
T4?
No, not regularly. But when we do if it's an MIBC, yes. And routinely, most of our tumors will be an MIBC. So we usually do an CT and then go for an TURBT. And after the HP report, then we'll ask for an PET CT, not in an upfront one.
Okay, yeah. So generally this part would be done by urologists and uro-oncologists, and then we come into the picture. So thank you, Dr. Preetham. So next slide, please. So we can go to the Dr. Supreet. So would you send samples for all these markers in bladder cancer? So like the way we do in cholangiocarcinoma and all, do you ask for any workup?
No, sir, because it barely makes any difference at this in this early stage disease. FGFR targeted therapies are not an option. PDL1, regardless of the score, we can offer immunotherapy, and HER2 anyway, there is no approval for its usage in early stage disease. So no.
Yeah, fair enough. Next slide. So this patient had T2A-N0, that is muscle invasive bladder cancer. Next slide, please. So this we have already discussed. So Dr. Preetham, would you discuss bladder preservation strategies if the patient is very reluctant, or you offer them to offer the bladder conservation protocol to your patients, or just tell them the day one that they have to be prepared for radical cystectomy after they come back from the medical oncologist?
No, sir. We always tell that these are other modalities which are available and which we can also do it. But we also tell that which is the best for them based on the individual patient.
So how would you counsel a patient if the patient is totally reluctant for cystectomy? Because you do often see patients where they say that they don't want the bladder to be removed. So how do you counsel them?
So based on the disease again, sir, like if the disease is small where the complete TURBT is possible, then I'll tell that yes, it could be one of the option for you where you can go for an TMT, trimodality treatment. But sometimes, or probably our two-third or 70% of the patients do have like where the complete resection is not possible, the multiple tumors are there, CAS is there, or there's an hydronephrosis where it is difficult for an TMT to be done, sir, in the most of the MIBC. But yes, in some of the NMIBC, yes, or an high-risk disease, it is possible.
Is there any role for partial cystectomy in patients who after they come back from neoadjuvant chemo, if
No,
they are
sir.
not willing for ileal conduit?
No, sir. It's a field disease, so we usually don't offer any partial cystectomy apart from adenocarcinoma and the urachal cyst, sir.
Yeah, a lot of learning points. Thank you, Dr. Pritham, for that. Next slide, please. So, are there any particular, this we discussed already, and also we should keep them under close follow-up if they do not undergo a radical cystectomy, and then prepare them and also counsel them for radical cystectomy at a later date. So, next slide, please. So, yeah, at this point we have discussed with the growing evidence for IO that IO has to be done in the neoadjuvant arm. And also, so when do you incorporate radiation? So we do have any radiation oncologists in the panel? So Dr. Preetham can answer this. So when do you refer your patients to radiation oncologist? Because we hardly do that. And if we are planning for trimodality therapy and the patient is totally reluctant, then only we consider radiation. So otherwise, do you consider referring to radiation oncologist any point of time?
No, sir. When the patient is not fit for any treatment, when in a very frail patient where they're having an active hematuria, which we are not able to control, then probably that's a very small. I've seen only one or two patients, old lady was there. So where I had to refer it to an radiation for that. It's like more of a salvage rather than treatment for her.
For any hemostatic purposes, do you refer them?
Yes, sir.
Yeah, hemostatic we may consider. Next slide, please. So you can tell us about the follow-up of patients generally, because after we treat, we refer back to uro-oncologists or urologists, and then they do the follow-up. So how do you advise follow-up for these patients? Because we are all well-versed with breast cancer and lung cancer follow-up, but we hardly do bladder cancer patients follow-up. So you can tell us or enlighten us about the follow-up.
Yes, sir. So the major difference between the patient with TMT surveillance and cystectomy is post-TMT patient requires regular cystoscopy once in 3 months. So that is most important because we have seen few of the patients who come back with the recurrence even after TMT also. So that's why the regular cystoscopies is the must. But otherwise, we follow up with an regular ultrasounds and then CT, which is same for TMT or the cystectomy, sir.
Yeah. So we have 5 minutes to wind up. So I would ask, we can stop the panel discussion in the according to the slides. Now we can. I would like to take points from all the panelists or all the esteemed members who are here. We can start with Dr. Anand if he's there. So one take-home message and the summary of what we have discussed today. We can start from Dr. Anand if he's there.
Yeah, I am there.
Yeah.
So so I think we've had a very exhaustive discussion. The takeaway points are a couple of points. The TMT is here to stay. I think we are underutilizing it, but then we have to choose the right patient for it. Niagara here is to stay. Maybe better chemotherapy.
Or EV Pembro, do you
combined
think
with
that EV
immunotherapy.
Pembro may displace? We didn't have the time to discuss about EV Pembro, which would be the game
Yes,
changer
EV
tomorrow.
Pembro in the adjuvant setting, new adjuvant setting is coming up. I think that's going to be a game changer. But then maybe better immunotherapy combined with chemotherapy, DDM back. I think we'll await the results on that. I think that is something that we all look forward to.
Thank you, Dr. Anand. Dr. Haridas?
Yes, sir.
Haridas, yes, sir.
So, sir, again, sir, as Supreet sir, Preetham sir, Balaji sir all said, Ravi sir also. So basically this durvalumab attacked in a micrometastatic setting early enough, and it had a synergistic profile with cisplatin. Hence, durvalumab worked well in the neoadjuvant setting, and it had a good PFS and OS benefit. So yes, so again, cisplatin eligible, cystectomy eligible patients, I would definitely opt for neoadjuvant durvalumab with the GC. Of course, Keynote 866 is coming up, sir. Yes, as how Anand sir said. So that's going to be a Italy versus Brazil kind of like a match that we ought to see.
Yeah, Dr. Preetham, your take-home messages for us, medical oncologists.
Yes, sir. Actually, with lot of options available, at the end patient is the winner because he has most of the options which he can choose from direct radical cystectomy to the neoadjuvant chemo, neoadjuvant immunotherapies. But we have to choose the patient basically probably when we are and yes, the tumor board is the most important thing in these kind of era and the setup. Because there are a lot of patients who has to undergo a radical cystectomy upfront when the disease burden is too much, or when the disease burden is less, where we do a complete TURBT. Yes, we can go ahead with the neoadjuvant settings, and when there is no obstruction or obstructive uropathy. But sometimes we may have to go in radical cystectomy upfront also, sir.
Yeah. Thank you, Dr. Pritham. We may see a day where when we start EV Pembro or more immunotherapy in the neoadjuvant setting where patients have complete responses, clinical complete response, radiological complete response. And there is advent of this ctDNA testing, which is evolving, and also TAR-200, that is intra-bladder vesicle bladder delivery system of gemcitabine. So we may see a day where cystectomy may not be offered for few subset of patients, for say carefully selected subset of patients. But tomorrow we should not be telling that as a standard of care. Radical cystectomy, of course, is a gold standard. Dr. Supreet, your take-home message points for us.
Yes, sir. Only one point between peri-op versus adjuvant immunotherapy. Peri-op is always.
Yeah, thank you. Dr. Vinu?
Yes, sir. Like you rightfully said, I think the neoadjuvant setting immunotherapy plays a much more important role, especially with combination chemo. But people achieving PAT-CR, should we continue adjuvant? I think that question we'll get in the future, and that
Yeah,
would
that
be
we'll
very.
always have that debate, and we have been having that debate for in triple negative breast cancer for long. Dr. Balaji Krishnan?
Yes, sir. Especially like with the split dose cisplatin, perioperative chemo immunotherapy made our life easily, especially in the Indian settings where like we can safely split the dose of cisplatin along with not compromising on the dose of immunotherapy and chemotherapy. Always the patient tolerability and quality of life is very important aspect when we are administering, because each cycle we will be assessing. So I think this trial gives us a extra hand in managing a patient who fall into subsite where we can administer and provide them better cancer control along with quality of life.
Yeah, it has evolved a lot, as Dr. Balaji Krishnan has mentioned, because we used to struggle a lot while treating bladder cancer patients with chemotherapy. Now it has become a lot more easier, and we have crossed that learning curve. And Dr. Ravichandran, your comments?
Even for like a platinum ineligible patients, we can use single agent immunotherapy. With that, we are able to get good amount of pathological complete response.
Yeah, you also brought out a very good point of chemo-free arm of pembrolizumab. So we may reach there with chemo-free, that is antibody drug conjugate and immuno arm tomorrow, and then cisplatin eligible, ineligible classification itself may no longer be there. So thank you one and all the panelists and the speakers. It has been a great learning experience, and then thank you one and all, and thank AstraZeneca once again for the opportunity.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.